Good afternoon. My name is David Potenziani. I'm a faculty member in SILS in the CHIP program. I get to host these things and usually introduce the speaker. And today it's particularly nice. Since the apocryphal Tower of Babel, human beings have struggled to communicate effectively. While all human languages do have similar characteristics, their structures are different, their vocabularies are different. And this has caused me many times in my attempts to speak French to make it a laughing matter to native speakers. And they were not laughing with me. But today we're going to look at a more recent edifice than the Tower of Babel. The ever-growing amount of data that is created by our healthcare systems actually, and this teetering structure threatens to topple over into ever-growing piles of mutually unintelligible information. And this gibberish, to use the technical term, is one of the subjects that we're going to hear about today. Dr. Melissa Haendel, who serves as the Director of Precision Health and Translational Informatics and is the Sarah Graham Kenan Distinguished Professor of Genetics at UNC Chapel Hill, is going to talk about interoperability at all scales. Today, she will build on her experience to talk about advancing the use and quality of data. She will discuss what is needed for driving research forward in a data-rich, nay, data-drenched environment. Dr. Haendel.
Thank you so much. I feel like I should get married now after that. That was beautiful. All right, so today I honestly didn't really know what to talk about with you all today, so I'm going to give you a huge smattering of just different kinds of things that our lab has worked on over the years. These slides have lots of links, especially for trainees, to go back and look at other things, so please feel free to go to the slides and find the materials for later. And the other thing I'll say is that there's nothing in this talk that anyone did all by themselves. It's really, our lab is very collaborative, and our lab collaborates with a lot of people around the country and around the world, and also here at UNC. And so it's really exciting to present some of the work that we've also done here with other collaborators at UNC. So interoperability at all scales, from data bits and bytes to national public health surveillance. So we're going to talk about interoperability today. And, you know, that might sound like kind of a boring topic, but it's actually not. All right, let's see if I can figure out how to make it go forward. Yes, okay. So first of all, let's talk about interoperability, because different kinds of interoperability affect all of us. So one kind of interoperability that we don't think of very much about in informatics is actually legal or licensing interoperability. And I'm not going to talk, I could give a whole talk just on that. I have spent years working with lawyers trying to license data for reuse and redistribution. And what is shown here on this slide is actually a real data slide that I made from all of these sources of data that we actually collected and their dependencies. It's like being a blood type. If you're A negative, that's a very different situation for your data than if you're O positive in terms of who can use your blood or your data. So restrictively licensed data can only be combined with permissively licensed data. And we spent a lot of time on the health data side, you know, working on data transfer agreements, data use agreements, EULAs, doulas. The acronyms just go on in terms of all the legal and licensing constraints. So there's a lot of interoperability constraints there. Regulatory constraints. Access control has to match provenance for regulatory permission. So if I'm a study participant and I say I want any of my data to be used for diabetes research, but then somebody comes along and they're an Alzheimer's researcher and they want to use the data, how does the system supposed to know that that person is not a diabetes researcher. So we have to have technologies that help us allow the right alignment of access control for what study participants are allowing their data to be used for. And hopefully we're moving towards a world where there's less, participants are encouraged to be less restrictive, but many restrictions still exist. Then there's system level interoperability, where platforms and tools often cannot talk to one another to move data and analyses. Take, for example, your Outlook calendar and your Google calendar. These things theoretically, should be more interoperable, but we have multiple other software solutions to help make those things talk to each other better. And if you too are having that problem, please come talk to me afterwards, because I have solved the problem. Mostly what we're going to talk about today is data and data interoperability. And data is often unencoded or coded in different data models, terminologies, formats, syntaxes, and it really limits our ability to search and analyze across different data modalities. Okay, so aggregation really doesn't cut it. So over here on the left, we have distributed data. We can have rich, high quality data. We can have use cases that are species specific or data type specific, but we often want to aggregate data across different contexts. Even just doing a Google search, we're aggregating data from many, many, many sources across the web. But that means that we can start to sort things and sift things with large scale indexing. That's great for general search and retrieval. But when we want to actually, do things like, look at big picture views like precision medicine, we need to know where all the puzzle pieces fit. We need to actually integrate data. And that's not something that you're going to get out of a search engine. And so how do we actually make it easier to do that? So we have a landscape of many source terminologies. We have ICD and SNOMED and RxNorm and a variety, MESH, and a variety of different terminologies. We have various systems and organizations that do mapping. We're going to talk a lot about mapping today. We have the Odyssey community that works on electronic health record data. We have the UMLS, and in the Odyssey, they map a bunch of terminologies to SNOMED. In the UMLS, we have a bunch of source terminologies that are all mapped to each other. And then in the NCI, we have the NCIT and the Enterprise Vocabulary Services. And these also have a lot of mappings from a lot of different terminologies. So everybody's mapping to everybody. So that's, one terminology to another. We also have a lot of coded data that has to be transformed. So in your electronic health record system, you'll have data that's locally coded. Those codes need to somehow be mapped to something that somebody can use on a national or international level if you want to do multi-site studies. And we have tons of unencoded data as well that needs to be mapped to something or new codes created. And then we have something called code sets. And we're going to talk more about those later as well, where we have sets of things that are derived from terminologies or value sets. And so there's all these different contexts of people mapping to everybody. So this is the chasm of semantic despair. That is me at the bottom of the chasm. Over there on the left, we have all the things of basic science research. I actually was trained originally as a basic science researcher, so I spent the first part of my career over here looking at genomics and proteomics. And then, but on the healthcare system side, we have very different kinds of data. We have, lab values and trials, clinical research data. We have medical imaging data, EHR data, other real world data. And these different types of data modalities are not really designed very well for interoperability. And there aren't that many people actually working very hard to cross that chasm of semantic despair. But if we want to really realize the promise of precision medicine, of public health surveillance, we have to be able to use the data that lives over here. And it's much more about the people than it is actually about the technologies. Like, we need to get the people to start speaking the same language. Okay, so the sides of these chasm are not actually so different. Over there on the top, we have clinicians, veterinarians. We also work with some veterinary data in our group. Patients, documentation, clinical coders, coding systems, EHRs. On the bottom with the basic science researchers, we have specimens, documentation, biocurators, ontologies, and scientific databases. they're not really that different. So we should really find ways to kind of connect these two worlds. So semantics are the universal converter. And if you haven't seen this already, it's a terrific XKCD cartoon. So the rest of the talk is really about all the ways that we can do this. So first example, we're going to talk about reconciling the world's disease knowledge. So there are a lot of different disease terminologies out there. We have disease terminologies for cancer, disease terminologies for infectious disease terminologies for rare diseases, Mendelian diseases, complex diseases. And you know, our lab works on rare disease diagnostics, and we needed a way to comprehensively gather the knowledge from, there can be rare diseases in many of these other categories as well, to really comprehensively gather all the knowledge and information about these different diseases. But is basically breaking our diagnostic tools when we used one source versus another, because they had differing definitions, they had differing criteria for inclusion. And so we set about to kind of come up with a strategy for reconciling these things. So why not just use all those mappings that I talked about before? So many terminologies and ontologies come with mappings. ICD is mapped to SNOMED. Why don't we just use those mappings? But the problems with these, and these mappings are useful, and we do use them, they're often mutually inconsistent. You know, one group will map in one direction, but not the other, or a term will be mapped to two terms in another terminology, but those two terms are mapped to three terms in the source terminology. And so there's n squared sets of mappings here, and there's just not one-to-one equivalence. And then the other thing too is the provenance. Who mapped them? Why did they map them? What were the rules for the mapping? Also not usually declared. So here's an example of things that had been mapped. So here we have on the left a classification of some rare diseases from Orphanet, where we have Zellweger syndrome down here, which is a class of peroxisome biogenesis disorder, which is a rare hereditary metabolic disease, and so on, in the NCIT, which now, mind you, this is the standard by which Europe does their trials and does research, and it's now required to have ORFA codes in Europe. NCIT is required for FDA submissions, and this is the classification in NCIT, and you can see there that Zellweger syndrome is a class of leukodystrophy, which is a non-neoplastic nervous system disorder. It doesn't look at all like it does over there in Orphanet. And then over here we have the disease ontology, which is used by the model organism researchers, and there, you know, we have some similarities, but we're missing a lot of the other classifications. There's dozens of these that look equally as different, right? So how do we, no wonder our diagnostic tools are breaking. Also, the information that's attached to these diseases is different across different sources. So, you know, ClinVar associates those diseases to variants. You know, our group in the Monarch Initiative, we associate diseases to phenotypes. The comparative toxicogenomics database associates treatments and toxicological chemicals to diseases. And ClinGen curates and defines diseases and their variants in terms of defining what diseases are. And so all these different groups are capturing different parts of what our actual attributes of diseases are, which are definitional if you put them all together, but no one group is actually capturing all that same information. So this is post-reconciliation. It's been about 5 years now to this point. And what this diagram is showing you is both the solution and the chaos. So in the middle, you'll see, this is now called the Mondo ontology, which reconciles all these different knowledge sources, really focused on rare diseases, but includes disease entities from all kinds of disease areas. This is one of the disease entities from that prior slide for adult refsum disease, and you can see the equivalent identifiers there in the column C in the middle in the different colors. You can see the synonyms that each of those sources have and where those sources come from with the sand key on the left. And then you can see which ones are actually equivalent and which ones are sort of have other kinds of relationships like broad to narrow or non-equivalent ID. So for example, we had in MEDRA, this term was mapped to phytanic acid storage disease, which is definitely not an equivalent term. And similarly down here for these other OMIM classes. And so some sources are just not mapping things, and we want to kick those mappings out if we're going to do diagnostics, because we want only the equivalent knowledge that's available. So keeping track of the provenance of all of this is part of the challenge that we've been trying to address with the Mondo terminology. And if you're interested in this terminology, you can go to that link. One of the exciting things that we were able to do, and we're just about to finish an analysis to redo this. This was published several years ago. Is that you know, our interests are in using this reconciled terminology for rare diseases for diagnostics. The knowledge that we get from different sources, we can now evaluate. So we took all the rare diseases from the known authoritative sources, and we evaluated which sources provide knowledge about each of those rare diseases across 5 commonly used sources: NCIT, the Disease Ontology, GARD, which is NIH's patient portal, Orphanet, and the online Mendelian Inheritance in Man. And what you find is that out of over 10,000 diseases, which you know, is a lot more than the quoted 7,500 diseases by the Orphan Drug Act, many diseases were only in one source, and only 333 diseases were actually in all 5 of those sources. That's extraordinary. That means that this fragmentation of knowledge is blocking all kinds of science, all kinds of diagnostics, because different groups are using different information. Our basic scientists are not accessing the information that might be in GARD or in the NCIT, for example. Okay, so now we're going to go on to mapping. Some curation rules and provenance, evidence, versioning, and attribution, some things that we've been doing to help kind of keep track of everybody's mapping to everybody. So another example, and this is a real example of why automated mapping doesn't always work so well. And this was created at a time pre-LLM, but it still exists and it's still used in computational pipelines, and it has not been changed. This is from a very commonly used terminology services organization. I won't name names so as not to make anybody cranky, but you'll find there on so these are a set of mappings that you can download and use in your computational pipelines from this organization. You have the human FMA extensor reticulatum mapped to the retina of the mouse. You have things like the, and we're going to come back to this example later, the human tibia mapped to the fly tibia. And you have the human colon mapped to the city of Cologne. Not useful. Okay, so we can actually use a reasoner to help clean up some of these things, which is in part how we created the Mondo ontology as well. So here we can look over here on the left and we can say, okay, we've got tibias. Here we've got a human tibia, we've got a mouse tibia. Human and mice are vertebrates. Vertebrates are disjoint from arthropods. So if you're a vertebrate, you're not an arthropod. We know this, right? So we can create a logical axiom that says these two things are disjoint. Now we say, okay, but and over here we have the fly tibia. Fly's tibia is part of the fruit fly. Fruit fly is an arthropod. We know that the tibia is a bone. And we know that bones are only in vertebrates. Now we can have an argument about that, but that's a separate talk. So we know that these two things cannot be made, that the fly tibia is not equivalent to the tibia of the mouse and the human because of this disjoint statement that we've made at the very top of this ontology that affects, you know, all the classification of all these mappings anywhere down lower in any of these graphs, right? So it's a very powerful tool to have these logical axioms help clean up our data, and using the reasoner to help clean up our data along the way. Here's another example just to kind of illustrate some of the types of mappings and how it kind of can be used to also create knowledge networks. So here, for example, we have Fanconi anemia A, which is a type of Fanconi anemia. This is mapped to the Orphanet code 84. We have another type of Fanconi anemia that is also mapped to that type, right? So again, this is kind of, you know, a challenge here. Here's the GARD term. And then we have, and this is also provided by automated mappings, the mesh term, which we index the literature with, for Fanconi syndrome. Well, Fanconi syndrome is not at all related. It was the same doctor, but the two disorders are extremely different. It's mapped to the Fanconi anemia. We also can, map and relate phenotypes like absent thumb. We can relate it to genes such as the FANK-A gene, and also to proteins. And so there's, in a way, some of the mappings, they don't just exist. And this is what I mean by those, when I had the slide up about all the different groups contributing different components, we can use reasoners and underlying logic to help bring these different things together, but we can also use it to repudiate mappings that are incorrect or not possible. And so these knowledge networks will come back later in the talk, and a lot of what our lab works on is building computational methods on top of these knowledge networks. So how do we keep track? As our group is often the case, we build a new standard. So this is a standard called a simple standard for sharing ontological mappings, or SESM. And basically what it says is that you can take a subject. Here we have adenofibroma. It has an identifier. It has a predicate. It says it's an exact match. It's an equivalency determination. And it has a target object ID. So this is the Mondo ID. And it says that the label here is adenofibroma here. And then there's the match label. We have the mapping date, the confidence, whether we curated it or used an automated method or an algorithm, who reviewed it, what the tool was, just all the metadata about how that mapping was created. And these are version files that are now publicly available, right? So now you can filter the mappings based upon this information. Well, this mapping was created by Melissa, so I definitely don't want to use it. Or if it was created by a tool that I know has a certain flaw, maybe I want to exclude those, that sort of thing. Okay, so mapping isn't just terminologies to terminologies. How can we map more complex mappings, such as common data elements and value sets? So there are over 1,800 databases, 1,500 standards, 900 ontologies, and 23,000 common data elements available to date, last we counted. And a lot of these are overlapping. So we have ones at NLM, we have the CADSR, FENX, HEAL, lots of those kinds of domain-specific ones. And the content and the metadata are basically implied, like including the mapping and the provenance. And so this is just like a couple examples. So date of birth should be pretty straightforward. There are 20 different 8 common data elements just in the NLM repository alone for representing date of birth. Think about why do we need 28 different ways to represent date of birth? Blood pressure, 104. Smoking status, that one makes a little more sense, 22. And this is how many ontologies that are related to these terms in one of the ontology services. So there's a lot of messiness out there. So here's the example for blood pressure measurement. You can see here, blood pressure, the definition, blood pressure measurement with systolic measurement over diastolic measurement. The NIND is the steward. There's a blank for the origin. Down here we have concept IDs. Over here we have, information about reference ranges. Again, missing concept IDs. And, this just goes on and on and on, right? So, and this is how our clinical research data is encoded with these common data elements that have, that sort of lack interoperability and also just lack specificity. So we need to think about mapping not just the value sets, but also the data models. So over on the right are the value sets. So here, for example, one group might record race as not reported white, American Indian or Alaska Native, Black or African American, but another group might do it this way. And so when we're mapping or integrating data from one clinical research study to another, we have to figure out what to do with, what do we do with not reported? Does not reported map to not allowed to collect, or does it map to other, or is it unknown? And it doesn't necessarily matter in this case which we choose. We'd have to choose something and we have to document it, right? And so that's what SESM is all about. So SESM allows us to document those mapping choices and rules. We also need to think about where the data model sits. So for example, over here, there's no direct link from, these are actually real examples, from sample to diagnosis in one data model, whereas in another, and in order to relate that to another model, we need to remodel this sample to case and diagnosis to case to align with the sample to diagnosis, so that the two the tables and their questions and value sets within them can relate to one another across those different clinical research data sets. Okay. So we have a toolkit called LinkML that the community has developed and we have contributed to, which you know, is kind of a whole community working to build kind of a variety of different tools and standards for modeling data and doing the semantic bindings to those value sets. So assigning terminology codes or Booleans or other features to your value sets. And so this toolkit allows you to define schemas, and it sort of closes the world of the you know, open world assumptions that we have in the semantic modeling space and the semantic web. And it allows us to bind and integrate ontology knowledge, and we have a lot of different tools that are available to generate alternative formats and validate data and generate transformations. And you can go to that link there if you want to learn more, and there's lots of community meetings. This is just an example of what we've done to create a pipeline for ingesting and harmonizing clinical research data. So taking the source data dictionary, checking to using the LinkML tools to see if the source data actually matches the data dictionary, which it almost never does. Building an automated schema for both of those things, and then manually curating and fixing the things that don't align, and then mapping that to a target schema that we might be using to bring in multiple different data sources, and then generating harmonized data with the full provenance that with all the bells and whistles that I talked about previously. So this is kind of another thing that we've done to kind of look at different CDEs across sources. So taking many different CDE repositories, getting CDE concepts, doing an LLM embedding model, and creating a clustering approach that we can then use to help try to identify CDEs that should be aligned. So what CDEs are we actually trying to create interoperability between based upon their clustering approaches? Also, we have another example on the next slide, I think, that we've been working with the CureGN. It's a rare kidney consortium that's been around for quite some time. And in this case, the same kind of clustering approach for those CDEs has been used to try to identify variables that they want to try to turn into CDEs. And so we compared their variables against those that are actually in the NIH repository, which you know, are shown in the blue color over here. And you can see that things that are unique in the CureGN are green, but there are some things in green over here that are either things that potentially could be aligned and integrated with known CDEs that are used in many other different consortia, or things that, you know, are maybe high priority that we might want to consider to develop as a CDE that might that are in green over here that might be useful for other community members to use. So it can help prioritize what should a CDE, how to create CDEs across the community. And this is just showing how we can apply some clustering methodologies to kind of delineate what those different clusters are, and then also helping prioritize, you know, making sure we're not unduly focusing on one kind of area or domain, and distributing our efforts. Let's see. Okay, now we're going to move on to my favorite topic, anatomy. I was really trained as an anatomist, so so this is these are anatomical silos. So back in the old days, every organism made their own anatomy ontology. So we even had several for some organisms. So on the left, we had the developmental anatomy ontology, and, you know, showing that, you know, the lung developed from the lung bud, developed from the respiratory primordium, developed from the pharyngeal region. The mouse phenotype ontology, you know, has a classification of abnormal alveolus morphology and lung morphology. The gene ontology, which how many of you are familiar with the gene ontology? So a couple. Okay, so gene ontology, respiratory system process relating to lungs, mouse anatomy, and then the human anatomy ontology. And so the blue are part of relation. So the alveolar sac is the part of the pulmonary sinus. It's part of the lung, which develops from the pleural sac and so on. So we had all these different silos and we had all these different gene expression data and phenotype data that was being captured using these different ontologies in these different communities. And so can we just map across them? Well, again, going back to our tibia example, possibly. So just wanted to provide an example, and this is maybe a lesson in hindsight for, how we can really get standard, people always ask me, how did you get the community to agree to something? It's hard to get the community to agree to things. So here we had a famous dinosaur biologist and a craniofacial surgeon. What do these two people have in common? Does anyone want to take a guess? Huh? They study faces, pretty good. They both study what's derived from the neural crust as their face, right? So the neural crust is a biological process about how many parts of your body get created, but especially the craniofacial bones. And it turns out that we had a very rigorous workshop with said famous dinosaur biologist on the cover of Sexiest Men in America, and an oral facial surgeon. And what the resulting ontology that came out the other end is really robust with understanding development and morphology, and it's helping drive that same ontology is now helping drive medical practice for residencies to make sure that residents are learning different kinds of surgeries on different parts based upon that classification. And it's also helping us understand evolution. So the result of that was an ontology called Uberon. You can learn more about this at uberon.org, and it integrates all those different kinds of ontologies and many more. And can generate different views. So now we have one ontology instead of all these silos where we can say, hey, I need a brain ontology that's, a vertebrate brain ontology. And we can just slice out the parts that are related to Drosophila or related to, non-vertebrates and the parts that are not related to the brain. Or we can make a taxon specific one. Let's make a mammalian ontology or a vertebrate ontology. And so that's been really useful for the community. And now we have one architecture that can help serve many, many different communities in an interoperable way, even as distant as a craniofacial surgeon and a famous dinosaur biologist. Also, Uberon helps standardize a lot of other ontologies. So if you have used the gene ontology, you probably have noticed there are a lot of anatomy and cell characteristics in there: brain development, hippocampal development, astrocyte development. All those terms come from Uberon. So you're really using Uberon without realizing it when you're doing gene set enrichment or things like that using the gene ontology. Okay, cross-species phenotype interoperability. So one of the things that we said, and I'm not really going to talk about the science of this today, but just to give you a little bit of premise, that there are around 19,000 human coding genes, and only about 9,000 of them are 9,700 of them have causal mutations associated with them. So we know that they cause a specific disease. So there's like a lot missing. And if we take the orthologs of those genes in the top most used model organisms like fruit fly and C. elegans and zebrafish and mouse, we get 76% coverage of the human coding gene. If we take the union, we get up to 87% coverage. So there's a lot of phenotype data available. Remember, crossing the chasm of semantic despair. There's a lot of phenotype data available from these model organisms that can help inform diagnoses for rare diseases in humans. And so after many years of work have been spent trying to create interoperability in the phenotype characteristics between humans and these model organisms. And so how do we do that? So here's a human phenotype, hypoglycemia, and it's represented by underlying logic, a decreased amount of lysine in the blood, right? It's pretty straightforward. Well, the mouse phenotype is not, they don't use the word hypoglycemia in the mouse. They use decreased circulating lysine levels. These words are not at all the same, right? You can't just do a text match. But the underlying logic of how those are represented is actually equivalent. They also represent this as a decreased amount of lysine in the blood. And because of that, and because of the classification of lysine as a chemical and blood as an anatomical structure, and even amounts, these are all ontological entities. We can use a reasoner to determine when things are related to each other in such a way. And so this is what that looks like in practice and how we use model organisms to help diagnose rare disease patients based upon that underlying interoperability across species. So here, for example, renal hypoplasia could be related using that same approach to a duplex kidney in the mouse model. And so that mouse model would then inform, because we know the underlying genetic variation in the mouse can inform whether or not a variant in the human may have that variant. That variant might be the causal cause of their disease. So this is how we bring that model organism data into the clinic. So we also, for those of you computationally interested in this sort of more translational space, there all of this data is made available and in a knowledge graph and also at an API. And I forgot to mention, I meant to put this on here, sorry, Sean. We have a chat bot on top of this that Sean O'Neill, who's here today, built. And it's a really great way to interact with the knowledge graph, just using a chat bot. Okay, so now we're going to talk about electronic healthcare data. So we have a vision of what we call putting the patient back together again. So when you go to the doctor, you have a clinical encounter, there's a record of that in your electronic health record. And you talk to your doctor and they write some notes in there. And the next time they see you, they say, oh, you know, how's your dog? Or, you know, did you move into your new house? Because they've written something in the notes about you. Great, that's lovely. We love that they do that, right? But they don't know that your dog, you know, otherwise they don't know that your dog died, that you haven't gotten any exercise lately, that you, you know, been eating really healthy, you know, or anything really about you in between those clinical encounters. And so we also have a tendency in medicine, in research, to take data and by its data type and ship it off to different places. So your genomic data goes to a genomic data repository, your imaging data goes to an imaging data repository, and never shall the two be reunited. We also have a lot of environmental and social influences on health, and we want to understand how those influence us as well. And so if we think about clinical research studies, we have, you know, we can contribute these actively at the point of when we enroll in a study. Here, this is the All of Us research study, but it could be any study. We could do surveys, genomic data, and these can, the nice thing about All of Us is these are actually collated instead of being separated, but they're still only available at the point of time after you've been recruited to a study. We have different linkage, passive acquisition approaches for getting information like claims data or insurance data, prescription data, mortality data that can be linked to you, and we can go back before you were recruited here. Similarly, we can acquire data because you were seen in an emergency room in another state and your provider that contributed data to the study didn't necessarily know about that through health information networks. And finally, we can do geocoding and link environmental and social data to your record and have this rich environmental and social history for you before the time that you were recruited. And so we have this goal of really bringing all these different data sources together. There's a lot of different kind of real world data or electronic health record data sharing initiatives around the world. Many of them are federated, and those are great for asking kind of specific kinds of queries. So how is time on a ventilator impacted by drug X could be sent to a set of data partners. They would all run the query, send the results back, and then you would aggregate and do some statistics on the results. And more people are learning how to do machine learning and other kinds of algorithmic work over these distributed networks, which is great, but a lot of them are computationally, a lot of the ideas that one might have are computationally intractable. It makes sense oftentimes to have centralized data so that you can do, you know, richer machine learning and AI types of approaches and more exploratory types of approaches where you can ask questions like in patients under age 60, which factors are most predictive of a severe outcome. Now, the challenges, of course, are that, remember all those licensing and legal and regulatory interoperability? This goes back to that. With centralization comes great responsibility and a lot of bureaucracy. And then also a need for security, right? This data needs to be kept more secure. So it's always good to try to think about these things in balance and their pros and their cons. And this is a slide that I credit to Emily. I love this slide because it's important to remember that in both of those contexts, the different data models have different expressivity and include different things. So here, for example, in the Odyssey community with the OMOP data model, the death date is required. If you died, we need to have the death date. And that's true. But that's not true in pCoreNet or in the ACT network. And it's not always clear about how these sorts of differences are encoded in all the different contexts or how much they've been adhered to in the different contexts until you centralize data. So always have, you know, skepticism about what lives behind those firewalls in the distributed systems because they might not actually meet all the criteria that you think they do. This is just an FYI if you are not familiar with the OMOP data model. So this is a kind of overview of all the content that's in that data model. And if the Book of Odyssey is a really wonderful resource for learning more about the OMOP data model, which is our favorite clinical data model. This example talks about that sort of like, what do we get when we actually, you know, centralize the data and some of the ideas that we have for how we can actually repair the data and use the fact that we have centralized data in mass to actually repair data. So here, for example, humans measured in grams don't really look the same as those measured in kilograms. When we got the data into a large data set, we basically saw that there was a lot of units missing. So if the units are missing, it makes it very hard to use in our various applications. But it's also, you know, fairly straightforward to repair that data to say, if you know that it's a simple, like, you know, transformation, we can actually repair data. And so this is showing a bunch of different labs that have units, and the green ones are the canonical units, and the blue ones are the ones that were actually able to repair algorithmically and then resuscitate those data having proper units. Okay, now we're going to move on to kind of a little bit about the pipeline of what happens when data comes out of your electronic health record and into your OMOP instance. This could be the same could be true for pCoreNet or some of the other common data models as well. But here, for example, we have our Epic Clarity or Caboodle. And then that information is, you know, the Odyssey pipeline is on the top. ICD is mapped to SNOMED via the Odyssey concept relationships. And so you can see there's a source value, and this is an IMO term, which is the Intelligent Medical Objects company, which does terminology services for your electronic health record system. This is mapped to an ICD-10 CM code, which is then mapped to SNOMED in OMOP. But what if we actually went straight from the IMO term to SNOMED and skipped the ICD-10 steps? So we're going to talk about, and this is about that mapping lossiness again, right? So here's an example where we had those IMO terms I'm going to go back. Well, actually, I can go back. Yes, I can. Okay, so just to read the next slide, you have these source values, these IMO terms. These are the things that we get out of our EHR through the IMO services. And the question is whether we can go, what happens if we go through this double hop versus a single hop? So here you can see the intermediate codes are, you know, each have a code for ICD-10. The indirect mappings that when we do the double hop, we go mesocardia to congenital heart disease, whereas the direct mapping obviously would have been mesocardia. Or we go Schoen syndrome to congenital heart disease. We're losing Schoen complex. So we are basically the clinician and the clinic are mapping things properly to the right IMO code, but because of the way that OMOP maps things, we're actually losing a lot of information. And this is what we're computing on. This is what the majority of people are now currently computing on in OMOP. This is actually what, if we just had the single hop, what we would be. Actually, we would retain a lot more of the clinical intent of that original mapping. It's kind of shocking. Here's an example. So this is an example for a disease area that we work on for primary ciliary dyskinesia, which is represented, quite well in the IMO services. The corresponding ICD-10 code would include 24 additional conditions that are not primary ciliary dyskinesia. So this increases lots of noise, as I showed you on the prior slide. It forces a manual chart review to identify correct patient populations or result in worse, poor trial outcomes, and also, as I mentioned, incorrect observational conclusions, such as drug responsiveness. So this is one thing that we're working on with EPIC and IMO and Odyssey to try to improve so that we can actually keep the original clinical intent. Okay, last topic here. I think we're getting close to the end. Wanted to talk a little bit about geospatial interoperability, because I think this is a really exciting new area for clinical informatics, and hopefully you guys are excited about this too. And so if you weren't familiar already, Hex3, which is comes from Uber's system. It's a geospatial representation. I'll talk more about that on the next slide. But just to kind of say that there's different kind of levels of spatial partitioning. So we have a census region, we have states, ZIP3, which is often commonly used in clinical informatics. But we're going to talk about is Hex3. Once you get lower than that in terms of really granular, you start running into privacy danger, right? And so we're trying to get better than that. I'll explain why. And so we're really excited about Hex3 right now and being able to use that in our clinical informatics applications. And this is all about, it's about interoperability, but it's also about linkage and the ability to do geospatial and geospatial temporal with your clinical data. So over on the left is a Hex3 aggregation showing the percentage of individuals with asthma. On the right, it's what it looks like with ZIP3. And you can see you got a lot of gaps, right? So doesn't the left side look better? So we can avoid dead zones and still retain privacy. This is also just another example kind of showing how ZIP3 are practically incomprehensible and huge in truly rural regions. And census tracts are also larger than Hex3. And so the Hex3 system can actually do a better job of providing more granular partitions for geospatial linkage. This is just an example workflow because I wanted to give the trainees especially a tool to go look at. But you can see here kind of a pre-parsed address over there on the left. And then, the geocoding input, getting its, geocoded location, and the output where we get our lat and our long. And then some considerations for accuracy when you're thinking about doing these kinds of geospatial analytics. And there's a number of different kinds of tools that are out there, but this is one of the ones that we've been using recently. Okay, so takeaways. Common modeling and identifier hygiene facilitates interoperability across domains and around the world at different spatial levels, including geospatial. We need all the organisms to understand biology and human health and cross the chasm of semantic despair. Real world data is messy, but if you can harmonize it and link it, you can reveal critical patterns, and good disease mappings and open science will save lives. We had a paper several years ago in the New England Journal of Medicine that really talked about the need for this kind of semantics in precision medicine. And so if you're interested in learning more, there's a link to that article as well. And kind of really thinking holistically about putting the patient back together again. Right, that's it. Perfect timing. Thanks, everybody.
Okay, I'm going to start with an online discussion, but then I'll ask people in the room if they would like while we're listening to the answer, I can get the microphone over to you. We had an interesting exchange online that talks a little bit about what the privacy concerns inherent in this process. And so it began this way. Why should sharing one's data be the choice of the person when all people will profit by what we learn from aggregated data from all types of people? Which prompted a chat reply, because each person has an autonomous right to consent to use of their personal medical information, which prompted this rejoinder, and society has no rights, with a caveat. I support no harm should come to a person versus personal privacy, particularly communicable disease. Please comment.
Okay, so first of all, I just want to say that I was invited this past year to Finland to the European Computational Biology Conference, and I believe this was recorded online if you're interested, to do a Finnish debate, which involves a sword. So if that doesn't catch you, then I don't know what will. But about this very topic, like, should we share data or should we not share data? And I think, you know, it's a very important topic. It's a very challenging topic, and it kind of, you know, there's many analogous kinds of topics. Should we all get vaccinated because it protects each other, right? It's the same kinds of questions. I think I personally feel that we have a right as individuals to the best possible precision medicine that modern medicine and modern technology can give us. And that is not possible without everyone sharing their data. Now, how we share our data and when we share our data is, I think, maybe where the real debate is. We would not be able to diagnose a rare disease person without having a reference genome. Somebody had to share their genome. We need population genomics. We have to have lots of genomes to know when you have a variant that's actually significant. So a lot of medicine is just simply not possible without data sharing. But I think, you know, coming back to those regulatory and licensing and legal issues, there's a big tension there about what is self-autonomy, you know, in such contexts versus, you know, how can we collectively utilize the data for goodwill, for societal purposes. I will say that I actually think we err more on the side of not sharing data. We really only do precision medicine in newborn screening and cancer for the most part. We could be doing precision medicine in so many other areas of medicine. When I go to the doctor, they always make you sign the HIPAA waiver form that says you won't be sharing your data. I say, no, give me the form that says you're going to share my data. And they say, we don't have that form. So every single time I do it, it's been years and years now. It's starting to change, though. There are starting to be organizations that actually do embrace the, you know, individual's right to actually share their data. So I feel I have the opposite problem where I'm not allowed to share my data because there's no vehicle for me to do so. So I think the answer lays somewhere in how and when and where and how we regulate those things more than the should we. But that's a very personal opinion. And we could spend the entire rest of our time talking about that. So I would urge us to not have a discussion about that any further. But hopefully that's helpful to those debating online.
So we have another question that came in on the chat. Do you see phenotype or OHDSI users or researchers as working in different silos or groups? Can they work together?
I do think that the Odyssey community is a very open sciencey community, but it's also, you know, all communities have their own kind of silos. They have historically not been very integrative with the basic science or bioinformatics community. And they also, please don't quote me on this. Does this get posted? Yes. Okay, well, then I'll be careful what I say. You know, I think that there's an opportunity to, and we've been working with the Odyssey community to really capture the provenance of the mappings that they do. So the way that the terminologies work in Odyssey is that they all map to SNOMED, but then create new identifiers for those concepts. And if we could unpack that with some of the SESM style mappings and provenance, we can actually create a better structure also for integrating those translational terminologies like Mondo or other community terminologies that are coming along quickly. So there needs to be a better strategy technically for doing that kind of integration, but they are actually partnering to work on those things now.
We have a question in the room. Let me get the microphone over.
Oh, boy.
Dr. Haendel, thank you for the excellent talk and great graphics. I really like some of those. So I'm Jessie Tenenbaum. I'm affiliated with both Duke and UNC. So thank you for letting me be on campus today. And I kept thinking through your talk, what about the era of ChatGPT? And I know people have talked about the fact that in the era of LLMs, we won't need standards so much. We won't need mapping. We won't need all of that. And so can you talk about that, or is the importance of data standards going to go away when we can have that sort of semantic richness in computing tools? And B, could all of this work, your knowledge graphs maybe inform? Like if you could train some of those LLMs with this structured knowledge, maybe that could make it even more powerful.
Absolutely. And there's whole talks to be given on those topics too. It's a great question. And I specifically avoided talking about LLMs for a reason, because it's easy to think that you could just throw an LLM at some of these things, and you can, and the results have not been very good, right? So far, diagnostic tools are not doing better with just LLMs alone. We are seeing extraordinary successes, though, as you point out, with combining underlying ontologies and knowledge graphs together with LLMs. So training the LLMs, but also just allowing it to iterate in ways that are more easy for the human in the loop to iterate. And we are hugely expediting our curation processes of the underlying data using the LLMs and the ontologies together as well. So it's been really exciting time for us. I think that the biocuration and knowledge engineering community is, having a little bit of an existential crisis right now, because obviously it's easy to just, everybody can be an ontologist now, right? But it gets things very wrong still. And, if we can, have the prior, endeavors really working together with LLMs, and it can really, expedite things, and we can really focus more on the tasks that really only humans can do, and have the LLMs really assist us and expedite some of the other work. For example, if I want to go out and find find me all the drugs that have been used to treat a given rare disease, I really can't even answer that question. It's so hard to query for that information. No LLM can go out and get me that information and tell me, go look at these papers that I can go and then read and confirm or deny, sometimes deny, whether or not that's actually a relevant association to make. And so that's just that simple example has hugely expedited our ability to create these associative data sources together. Especially when it's not only from the literature, but other authoritative sources that are on the web. So, yeah, huge area of research. And I think there's a lot of work in LLMs in medicine right now, but not as much as I would have hoped, using the ontologies as an underlying resource as part of that work. So I think it's exciting time.
There are a bunch of people online.
Yeah, so I liked your point you made at the beginning. You said something about how so much of it's about people and getting people to communicate. But kind of going off of that, I think so much of it too is about money and funding. And I can imagine this is kind of thankless work. Like maybe it's not always in a researcher's, even though we need harmonized ontologies, it's not always when a researcher as an academic is trying to get a paper out to get a grant. And also the metabolomics and proteomics platforms that are developing, they're just expanding so quickly, and they're about the money and getting their platform in use. And so I guess just going off of all of that from your experience, and also just seeing how much new data is always being generated, what does the funding side of things look like? And have you been able to advocate for the NIH to kind of have grants focused on this topic, which is so important, but maybe doesn't fall within one of the silos of the NIH agencies? And yeah, just what does rallying people to do this work look like from your perspective? Just curious.
That's a really great question. It has been historically very challenging to find funding to work on this kind of knowledge engineering, ontology, standards, identifier management. I mean, who writes a grant about identifier management, right? It's like not sexy. What do you write in your innovation section? I actually literally have written in my innovation section that not being innovative is innovative, because we're trying to standardize. We're trying to not develop another thing. We're trying to make it so that your thing is the same as my thing, right? So it has been a challenge. However, and despite, the current funding climate, that we have actually seen, more interest in this kind of work recently, even in light of the LLMs, revolution happening. I was at a workshop recently that was a shared workshop between NSF and NIH on knowledge graphs. And they were handing out supplements to anybody who had anything funded that until 2027 that had knowledge graphs in it. And I was like, but I've been trying to get my knowledge graph funded for years and years. And unfortunately, they had just taken away all of my funding renewals. So I was not one of those candidates, but that's exciting. This is something they had no interest in before. So, and similarly, there's a whole new Office of Data Science that, is really, I think, trying to promote the use of standards. At the same time, NIH, also develops a lot of their own standards. And so there's sort of some competition between the community and the NIH itself. And so I think that's hopefully something that is also improving, and there's been more collaborations lately. But then I think, to answer your question, like, well, why do people do it? Said dinosaur biologist and craniofacial surgeon, because they're passionate about it. The people who are building these kinds of resources, they're going to do it no matter whether there's funding or not, because they wake up in the morning and they're like, I really want to classify the ossifications on this taxa of fish. You just can't help yourself, right? So there's just always going to be some passionate people like that. The challenge, though, in that is that, and it's really fun when you get any kind of community together like that. And I do think the Odyssey community, and it is one of those communities that has a lot of passionate people in it. But you can also get voices that are too loud and can dominate. And so that's something to be on the lookout for, is that, like, even if they're really positive and, genuine, like, it's easy to end up with bias. There was a great study on the gene ontology evolution, and you can see how different parts of the ontology are evolving over time. And we are looking under the streetlight, right? So one of the challenges that we do have is that, like, we work on the things that we're passionate about. If you're passionate about fish ossicles, but not, strange mammary glands in distant, mammalian taxa, you're not going to have those things represented in your ontology. And so, I think actually this is where some of the computational methods can help us look to see where are we not looking, right? Better, where, the dark genome is a good example. So that is one of the downsides.
Unfortunately, we're out of time, even though we could go on for a very long time. Thank you very much. This was extremely interesting.
Thank you so much for having me. It's an honor to be part of CHIP and to have a CHIP student. So thanks for having me. Sure. Here, come over here so I can hear you better.